monthly journal monthly journal club. Today our topic of discussion is decoding osteoporosis, understanding the disease, exploring current and new therapies and emerging targets. So today our presenter is Dr. Aanchal ma'am and her fellow Dr. Aarzoo. Dr. Aanchal ma'am is head at BLK Hospital and Aarzoo is doing FIPM fellowship in BLK Hospital. And myself, Dr. Deep, I will be moderating the session. We have two faculties, one guest faculty, Dr. Vineet Surana sir. He is HOD Endocrinology at Manipal Hospital, Dwarka. And our Society President, Dr. Ashu Jain sir, Head of the Department and Chairman, Artemis Hospital, Pain Medicine. May I ask Dr. Aarzoo to please start?
Yes, sir. So is my screen visible?
Yes.
Good evening to the faculty. I'm Dr. Aarzoo, Fellow in Pain Medicine under Dr. Aanchal ma'am. So the topic for presentation is decoding osteoporosis, understanding the disease, exploring current and new therapies, and emerging target. Osteoporosis is one of the most prevalent metabolic and non-communicable skeletal disorder worldwide. It is characterized by decreased bone mass and accelerated deterioration of bone microarchitecture. Fragility fractures are often associated with osteoporosis and is commonly seen in distal forearm, especially in distal radius, because of its susceptibility to low bone mineral density. Hip is particularly affected due to weight-bearing activities. The spine experiences vertebral compression fractures that leads to pain and postural changes. Osteoporosis globally affects 200 million people. It is a cause for 9 million fractures per year. It affects 33% of women and 20% men over the age of 50 years. Osteoporosis is further divided into two parts, primary and secondary. Primary is further divided into type 1 and type 2. Type 1 is postmenopausal osteoporosis, which is generally seen in 50 to 70 years of female. Type 2 is age-related. It is seen in more than 70 years of people, and it affects both trabecular and cortical bones. Secondary is secondary to any medication, illness, such as glucocorticoids, chemotherapy, protein pump inhibitors, and antiepileptics. Some risk factors are when weight is less than 58 kg, smoking, family history, Asian or white race, early menopause, previous surgeries or history of fall, and poor diet. Bone development. So how bone development happens? It begins in the embryo at 6th to 7th week and is continues up to 25 years of the age. There are two distinct pathways. One is intermembranous ossification and another is endochondral ossification. Both of these pathways are originated from mesenchymal precursors. In intermembranous ossification, these mesenchymal tissue directly differentiates into bone without any cartilage intermediate and forms flat bone of skull, clavicle, and cranial bones. Whereas in endochondral ossification, these mesenchymal tissues first form a cartilage templates, which is further replaced by bone. They govern the development of axial skeleton and long bones. Then remodeling bone cycle. It happens throughout a human life, and it includes three different phases. First one is activation. Whenever there is a triggering stimuli, whether it's a mechanical signal to osteocytes, which are mechanosensors in bone matrix, or any systemic or hormonal signals through parathyroid hormone or systemic cytokines, it triggers remodeling cascade. As we can see in this image, these are osteoblast and these are osteoclast precursors. Osteoblast release receptor activator of nuclear factor, kappa B ligand, protein, and OPG. OPG counteracts the effect of rank L. This rank L acts on rank receptors which are present on osteoclast precursors and causes differentiation of these osteoclasts and form mature osteoclasts, which are multinucleated cells. These multinucleated cells also have rank receptors present. So rank L act on these rank receptors and causes activation of osteoclasts. Once the osteoclasts are activated, resorption pathway is activated. Osteoclast then attaches to the bone surface and form a sealed reabsorption zone, and thus producing H positive ions and cathepsin K release, which causes bone matrix degradation and breakdown of collagen in this acidic environment. There's release of calcium and phosphate in the bloodstream. There's also release of growth factors such as insulin growth factor 1 and 2, which stimulate osteoblast activity, transforming growth factor beta, which regulates bone formation, and platelet-derived growth factor, which promotes cell growth and repair. All these together prepares the bone for new bone formation. Then comes reversal phase. It is known as handover stage between osteoclast and osteoblast. Here the work of osteoclast is completed and then they undergo apoptosis. Simultaneously, we can also see the synthesis of proteoglycans, which construct a cement line, or also known as joining interference between the old bone and a new bone. Then comes the formation phase. In formation phase, osteoblast replaces reabsorbed bone through deposition of new bones, thus completing this substitution pathway. Osteoclasts also synthesize osteoids, which are soft, unmineralized organic bone matrix, which further in the mineralization process get hardened. And so they form a scaphoid of the new bone. Growth factors released from the bone matrix during reabsorption phase act as a chemotactic agent for preosteoblast and promotes the proliferation of preosteoblast. Preosteoblast then produces a material that helps to bind the newly formed bone to the pre-existing tissues. As they also express bone morphogenic proteins, which are essential for osteoblast differentiation. Then comes the mineralization phase. This phase starts approximately 1 month after the osteoid deposition has taken place by osteoblast. Trabecular bone takes 90 days to complete this process, whereas cortical bone takes 130 days. In mineralization, there's deposition of calcium phosphate nanocrystals in the soft organic matrix that especially take place in the primary site of osteoid matrix. There is also growth factors present in the matrix that regulate osteoblast activity and bone remodeling. Then comes the quiescence phase, which is known as the resting phase, where bone returns to its normal functional state and remain in this phase until the next triggering stimulus is present. This is cyclic depiction of what we have just learned. The first step is activation and followed by resorption. Then there is reversal phase, followed by reformation, mineralization, and then resting phase known as quiescence phase. As we all know that osteoporosis is a multifactorial condition and it is affected by various conditions such as genetic factors or lifestyles. As we have earlier seen that secondary osteoporosis is secondary to any drug or any hormonal changes, such as estrogen deficiency in postmenopausal women enhances osteoclast production and prevent apoptosis. It also upregulates inflammatory cytokines which amplify production of immature osteoclast. With the hyperthyroidism and secondary parathyroidism, further acceleration of bone resorption is seen. Drugs such as glucocorticoids is the most common cause for drug-induced osteoporosis, and increase in fracture incidences by 30 to 40% is seen. They impair bone cells formation by disrupting bone remodeling and reduces the bone density in a dose-dependent manner. The risk for fracture normalization is seen when we discontinue the drug. Prolonged use of protein pump inhibitors is also associated with increased fracture risk. It has two separate mechanisms. First is hypergastremia that activates osteoclastic precursors, and another is hypochlorhydria that impairs calcium and magnesium reabsorption, secondary to hyperparathyroidism and enhanced osteoclast activity. Liver enzyme inducing anti-epileptics such as phenytoin or thiobarbiturates, they increases the risk of fracture in complete body by 86% and increases the risk of hip fracture by 90%. They activate cytochrome P450 enzyme, thus accelerating vitamin D breakdown into inactive form, causing hypocalcemia and secondary hyperparathyroidism. Other drugs that may cause osteoporosis include aromatase inhibitors, which are used in breast cancer therapy. They suppress estrogen synthesis, causing bone loss at rate twice that of which is normally seen in postmenopausal women. Gonadotropin-releasing hormone agonists, they are given to treat prostate cancer, breast cancer, or in endometriosis. They interact with gonadotropin release hormone receptors, which are present in pituitary gland. thus reducing formation of sex hormones such as testosterone and estrogen. Decrease in this sex hormone results into decreased bone density and increasing chances of osteoporosis. SSRIs interfere with serotonin receptors on bone cells such as osteoblasts and osteocytes, leading to change in bone remodeling signaling pathway. It is associated with 3.9% bone mineral density reduction in elderly men and is associated with the increased non-spinal fractures in elderly women. The cause for that is still unknown. In loop diuretics, they causes reduced reabsorption of calcium at the level of loop of Henle, thus promoting increased calciuria and potential hypocalcemia, resulting into lowering bone mineral density. There is a compensatory pathway where parathyroid hormone-dependent vitamin D activation partially offsets this effect of loop diuretics. Diseases that induce osteoporosis are hyperthyroidism that accelerate bone remodeling, where rate of osteoclast bone resorption outpaces osteoblastic bone formation, thus reducing bone mineral density, elevating hip and vertebral fracture risk. Osteosarcopenia. This condition involves both osteoporosis and sarcopenia. In osteoporosis, there is decrease in bone mass intensity, whereas in sarcopenia, it's a degenerative condition in muscular tissue causing reduction in muscle mass, strength, and function, either due to poor diet, aging, decreased physical activity, or disorders like diabetes. We can check muscle strength by hand grip strength function using chair rise time and walking speed of a person. And it has a mechanostat hypothesis that says mechanical forces from muscle on bone surface, if exceed a certain threshold, stimulate bone formation. If less mechanical loading is there, then bone resorption increases. It is usually seen in older age group, as in older age, physical activity decreases. In CKD, there is impaired renal activation of vitamin D to calciferol, which reduces intestinal calcium absorption, and thus activating a compensatory secondary hyperparathyroid release, is which drive increasing bone resorption to maintain serum calcium. This cascade lead to renal osteodystrophy and osteoporosis. It can be managed by vitamin D supplementation, dietary modification, and targeted pharmacotherapy. In diabetes mellitus type 1, there is deficiency of insulin and insulin growth factor 1 during the critical bone forming years, thus decreasing bone mineral density and increasing risk of hip fracture. Whereas in type 2 diabetes, there is no lower bone mineral density seen, but glycated end products impairs collagen cross-linking, reduces bone quality, and increases fall risk from neuropathy or hyperglycemia, thus increasing risk of fracture. Diagnosis can be made with the help of dual energy X-ray absorptiometry. DEXA is gold standardly performed in femoral bone. Here the femoral neck. Here the result is assessed using T-score, where we compare the patient bone mineral density to that of a healthy young adult. The normal score is when T-score is more than or equal to -1. Osteopenia is when T-score is between -1 to -2.5, and osteoporosis is when T-score is less than equal to -2.5. The usual sites where DEXA scan is done involves hip, femoral neck, and spine. In older adults, degenerative spine diseases may be present, or they may have a vertebral compression fracture or a herniated disc. They shows a false elevated bone mineral density reading. In osteomalacia, bone matrix is reduced, thus underestimated bone mineral density is seen on DEXA scan. Risk assessment tools also includes FRAX, which was proposed by WHO, which estimates 10-year probability of major osteoporotic fracture, widely validated and used to guide treatment threshold, particularly in postmenopausal women aged between 70 to 85. Another is trabecular bone score, TBS. It assesses bone microarchitecture and texture, providing information of fracture risk independent of bone mineral density, particularly useful in conditions like diabetes, where bone mineral density may underestimate fracture risk. QTC, quantitative CT. Here, 3D volumetric bone mineral density assessment is done. It distinguishes between trabecular and cortical bone. It offers a greater sensitivity when compared to that of DEXA scan, but involves higher radiation and is quite expensive. Q fracture clinical algorithm incorporates a broader range of clinical variables like age, gender, medical history, and lifestyle. Thank you.
Thank you, Dr. Aarzoo. This was a very exhaustive and elaborative article. So for all the viewers and audience, this only half part is finished, and next half, which is more detailed and which must be very new for all of us, will be taken up by Dr. Aanchal ma'am.
Good evening, everyone. Let me share.
Good evening, Dr. Aanchal.
Good evening, sir. Is my screen visible, Deep?
Yes, ma'am.
Okay. So slideshow. Okay. So you all, I hope, understood the metabolism. How vitamin D, calcium is regulated in our body, how we diagnose osteoporosis, what are the risk factors, primary, secondary, how we actually diagnose it. Once we have diagnosed it, let's see how we manage it. So there is a non-pharmacological management first. So first is exercise. They say resistance training stand out among the all exercises technique for its ability to sustain skeletal muscle. Because if you noticed in the previous presentations, there was some mention of osteosarcopenia, which is bone is weak as well as the muscle is weak. So if both are weak, it's like more damaging, more painful. So resistance training is something which is really helpful in promoting bone development and strength. And then weight-bearing exercises. In nutrition, of course, calcium, vitamin D, because they are the main strength of the main base where the bone is made. So calcium, vitamin D, if you take in the diet, it enhances calcium, magnesium, and phosphate absorption in intestine. Vitamin D is two main types, D2 and D3. D2 comes from plants and D3 is produced in the human skin via sunlight and also obtained from animal-based food. So balanced diet is very important with plenty of fruits, veggies, and proteins, and of course, lifestyle, smoking cessation, and reduced alcohol intake. So we have discussed this vitamin D and calcium physiology in the previous presentation. So in vitamin D, just skin, when we form D3, it comes to liver, then kidney, calcitriol, and through the parathyroid genes, they are inhibited and increased serum calcium level is increased. The recommended intake for vitamin D is more than 800 international units per day, and calcium is 700 to 1200 milligrams per day. Patient undergoing bone focus therapy need both calcium. So this is, I've put this point because I've noticed many times patients being put on therapy for bone resorption or bisphosphonates, and they are not given calcium and vitamin D. So patients undergoing bone focus therapy need both calcium and vitamin D, completely benefit from these treatments, which prevent secondary hyperparathyroidism and hypomagnesemia and on the bone metabolism disorders. So this is just a pictorial diagram of vitamin D, how it's changed to calcifidiol and then calcitriol, which helps in both increasing the absorption of calcium as well as bone mineralization. So coming to the pharmacological management, we have two agents, anti-resorptive agents and anabolic agents. Anti-resorptives is which decreases the resorption of the bone, which includes bisphosphonates, selective estrogen receptor modulators, denosumab, calcitonin, and anabolic agents which forms the bone. They are teriparatide and abolaparatide. So coming to the bisphosphonates first, anti-resorptive group, they are the first line drugs. So examples in first generation includes etidronate, chlorronate, and telidronate. We don't use this anymore. Second and third generation, why they are second and third? They have a nitrogen side chains. And the examples include alidronate, ibandronate, pamidronate, and so forth. So this is the diagram. In the end, we'll just, I have taken parts of the whole diagram which was given in the the article if you have read it. So if you see this pre-osteoblast, pre-osteoclast is changed to osteoclast. So nitrogen bisphosphonates and non-nitrogen bisphosphonates, they are causing apoptosis of this osteoclast. Hence, they are anti-resorptive. So, and the advantage of having nitrogen side chain is binding of nitrogen-containing bisphosphonates with bone material allows them to remain in the bone matrix for extended period. So even though they are for short term in the bloodstream, they can still be present in the bone. So mechanism we have discussed. Clinical benefits includes vertebral fractures and hip fracture reduction. So alendronate, this is the oral form. The dose is 70 milligram. You give either weekly or 10 milligram a day. This needs to be consumed after overnight fasting. And this is recommended for preventing glucocorticoid-induced osteoporosis and also postmenopausal women. So you need to stand for 30 minutes to decrease the chances of any adverse effects. This is the particular notorious one to cause more upper digestive problems. So resitronate, this is the third generation one. Osteoporosis in postmenopausal as well as men with osteoporosis. The dose is 35 milligram weekly or 5 milligram every day. So zolitronic, this is the IV form. This is particularly useful for treating diverse bone conditions like, of course, osteoporosis, but then Paget's disease of bone or bone mets in cancer patients. So their first line treatment for postmenopausal osteoporosis or for those who has expanded chances of fracture. We just in the previous presentation, we saw all the risk factors for developing osteoporosis. So management of inorganic pyrophosphate levels in hydroxyapatite crystals in bone is critical for the onset of new bone formation. But this, for most people, this pyrophosphate levels are regulated automatically in the body. And there is no established diet where you can increase or decrease this. But if you treat the underlying disease, correcting underlying disease, that means if the patient is taking glucocorticoid or any other risk factor which is actually causing osteoporosis, and then you correct the phosphate, calcium, and vitamin D abnormalities, then inorganic pyrophosphate levels will be adequate in the bone. So coming to another one, denosumab. This is a monoclonal antibody. So target is rank L. You just saw how rank L was important in osteoclast. So I've just made a little osteoblasts bind to produce rank L, which binds to rank receptors on osteoclast. And then they form these binding tells the precursor cell to survive, multiply, and mature into active osteoclast. So this rank L produces a lot of osteoclasts. And this denosumab, what it does is, it is a receptor. So it inhibits this rank and rank L interaction. So in response to decrease in estrogen, osteoblasts and osteocytes generate rank L protein. And denosumab binds with rank L, inhibiting its interaction with rank and hence decreasing the osteoclast activity. So this is the diagram, the part of that diagram, which is showing you, if you follow my cursor, denosumab is inhibiting the rank L. So side effects includes weakness and fatigue, which are most common. Advantages, it has shown the reduction in vertebral fractures, hip fractures, non-vertebral fractures in postmenopausal. And patient must smoothly switch to oral bisphosphonates after stopping denosumab or other anabolic treatments to prevent further bone deterioration. The next is selective estrogen receptor modulators. So what they do is they inhibit osteoclast again by promoting their apoptosis, and also they increases the activity of osteoblast. If you follow the cursor, this SCRMs are in the center. On one side, they are inhibiting osteoclast. On the other side, they are having a positive effect on osteoblasts. So they are decreasing the resorption and increasing the formation. So examples that have received authorization for osteoporosis treatment is raloxifene and lizavoxifene. Postmenopausal osteoporosis and the decreasing the breast cancer risk is the additional advantage. So we discussed that so raloxifene, what it does is it attaches to the estrogen receptors. On one side, it activates estrogenic pathways on bone, breast, and uterus, and other side, it blocks it. It manages bone health, additionally also cardiovascular health by decreasing low-density lipoproteins, fibrinogen, and lipoprotein. It is indicated in postmenopausal women who have high chances of invasive breast cancer. And then high risk is determined by the factors of either you have a family history of breast cancer or specific findings on breast biopsy or 5-year estimated likelihood of breast cancer exceeding 1.66%. Then coming to the anabolic therapy. So parathyroid hormone analogs, what they do is intermittent parathyroid hormone stimulation increases osteoblast activity. An example most commonly uses teriparatide. Indications, again, very high risk fracture, osteoporosis due to prolonged glucocorticoid treatment. So they say it only should be used in for high fracture risk individuals who have not responded to previous osteoporosis medication rather than using it as a first line. So it is beneficial if the patient has severe osteoporosis or very low BMD, multiple fragility fractures, or failure of first line therapy, or patients who cannot tolerate the bisphosphonates. Then calcitonin, it is mainly indicated in Paget's disease of the bone who are unable to tolerate bisphosphonates. Clinically proven to alleviate bone pain, reverse neurological deficits, and also improve hearing loss in patients with Paget's disease. So unlike bisphosphonate therapy, which requires 3 months to achieve maximum suppression of bone resorption, it reaches peak impact on osteoclast within 24 to 48 hours. So it is a preferred choice where immediate surgery on affected bone is necessary. So these are the current therapies we discussed. What are their limitations? Bisphosphonates causes GI irritation, osteonecrosis of jaw, more common in cancer patients. Why? Because their bones are already weak, and you tend to use high doses of bisphosphonates in this. Then atypical fracture. Denosumab is bad effects on skin. Again, osteonecrosis of jaw and rebound bone loss. So as I mentioned earlier, when denosumab therapy is finished, patient needs to be switched on some oral bisphosphonates. Then selective, same estrogen regulating moderator, hot flashes, leg cramps, risk of thromboembolism. Teriparatide, actually, by its second line, see, there is uncertain safety and efficacy. And animal studies suggest the risk of osteosarcoma because they're bone forming, but still relevance to human is uncertain. Calcitonin has its limitation because it has a short half-life, so it requires frequent dosing. And there uncertain effectiveness in postmenopausal osteoporosis and also potential for antibody development. So it is non-preferred option for first-line treatment of hypercalcemia. So now we'll come to the emerging drugs, which are new in the market. So romosumab is one of them, and how it is the first FDA-approved monoclonal antibody designed to inhibit the sclerostin. What sclerostin does is, if you see this diagram, it is inhibiting this WNT by beta-catenin pathway, which is an important pathway in the bone formation. So antibody, which is inhibiting the bone formation, it is inhibiting it. So this is the first thing, the dual effect of increasing bone formation and also decreasing the resorption. Then second emerging drug is sinacalciset, and it is calcimimetic. How it works is, it works by activating the calcium sensing receptor on the exterior of parathyroid cells, and it also lowers the parathyroid hormone level. So it is very, very beneficial in secondary hyperparathyroidism. The next emerging drug is teluroside, and it has an anti-inflammatory and bone protective action. So the way it does is, it has anti-inflammatory effect because it inhibits the excessive production of nitric oxide and also reduces the expression of many inflammatory enzymes. And the second action, anti-osteoporotic, it does is, it reduces rank L-induced bone resorption and also inhibits the formation of and activity of bone osteoclast. So teluroside helps in osteoporosis by reducing the osteoclast formation, limiting bone breakdown, and decreasing the oxidative stress. So these are the future therapeutic targets. So you can see there are multiple targets where people are working in if they could be hope to the osteoporotic treatment. So just a slide about all of them. The WNT beta-catenin signaling pathway, it promotes differentiation of mesenchymal stem cell into osteoblast. So this the mesenchymal stem cell, which was going to be differentiated to fat cells and cartilage cells, then this is inhibited and bone formation is encouraged. So these are all the types of WNT beta-catenase enzymes which they use, drugs which they use. So it can again increase bone formation and also reduce the bone resorption. And second is fibroblast activation protein. At therapeutic potential is osteoclastin, which is a natural FAP inhibitor found in joint cartilage, has shown to improve the bone density and reduce the risk fracture. So FAP contribute to bone loss by impairing osteoblast function. So if you inhibit this FAP, then you can preserve the factors like osteolectin and promote the bone formation. Third is NLRP3. It is a protein complex that regulates the release of inflammatory cytokines and that triggers pyroptosis. So how it helps in osteoporosis? Excessive activation, especially during aging or low estrogen states, contribute to osteoporosis. If it increases the osteoclastogenesis, it increases the formation and activity of osteoclasts.
I'm audible.
There was some internet issue. I'll just turn off my thing and I'll share the slides again from where we stopped. So, so we were discussing about the NLRP3.
Yes, sir.
So next is copper-induced cell death, cuproptosis. So while normal copper levels are necessary for health, excess copper is toxic and trigger this cuproptosis. So they say the copper has double effect on the bone. Effect of excess copper is bad for the bone. It down-regulates certain enzymes, reduces bone formation. And the excess copper, it damages lipids and bone cells as well and increases the production of rank L and promotes osteoclast activity. So it's a complex relationship with bone health. If you take adequate dietary copper, it is associated with higher bone mineral density and lower osteoporosis risk. However, if copper becomes excessive, it can damage bone and impair the bone remodeling. The next is P2X7 receptor. It is a ATP-gated ion channel which plays a crucial role in bone hemostasis by regulating both bone formation as well as bone resorption. So it has a therapeutic potential because it is a key regulator of bone remodeling, mechanosensing, and inflammation. And hence, as it influences both bone formation and resorption, this could be a novel strategy for preventing and as well as treating the osteoporosis. So next is TRAF3. This also is a mesenchymal progenitor cells which promotes differentiation into osteoblast. It reduces rank L production and hence again enhancing bone formation and limiting resorption. Next is Kruppel-like factors 3, KLF. So KLF2 and KLF10 are beneficial targets because they enhance osteoblast and bone formation. But KLF3 and KLF15 contribute to osteoporosis. So therapies could be made which inhibit this. So modulating KLF activity may provide promising therapeutic strategies for prevention and treatment of osteoporosis. And again, TLRS, it also plays an important role in bone remodeling and osteoporosis. It is a key transcription factor required for osteoblast. So if this TLR4 contributes to osteoporosis as it increases the inflammation, bone resorption. So if you have the inhibitors or modulators, that could be promising therapeutic strategies for preventing and treating osteoporosis. Then YAP and TAZ, they are important regulator of mesenchymal stem cell. So they stimulate osteoblastic activity and promote the bone formation. So targeting this pathway, of course, offer new strategies for preserving the bone health. Then SIRT3, same key regulator of bone metabolism and preserving bone mass and strength. So in summary, osteoporosis is a major global health challenge. Bone remodeling imbalance is a central pathology. Either you have an increase in osteoclast or decrease in osteoblast. DEXA scan remains diagnostic gold standard, and we discussed the criteria of osteopenia and osteoporosis. Bisphosphonates remains the first-line therapy. Romosumab represent a major therapeutic advancement. Novel molecular targets offer future opportunities. Overall, osteoporosis management is shifting towards the targeted molecular therapies that regulate inflammation, oxidative stress, stem cell differentiation, and bone remodeling pathways. So romosumab, teluroside, and teriparatide plus sinacelcicid combination, we saw like how it works, and everyone has its advantage and disadvantages. And these are the key emerging molecular targets. So this is still in the experimental phase. And this is the diagram we discussed. You can see one side on the left side of the screen, osteoclast bone resorption is going on. On the right hand of the screen, the osteoblast and bone formation thing is going on. And there are different medications written in the red, which has their action. They are inhibiting bone resorption or they are adding to the bone formation. Thank you.
Thank you, ma'am. Thanks a lot for sharing your experience and making the routine pharmacological agents simple to understand. And obviously, this was a very elaborative article
Especially
expressing
the experimental drugs.
a lot of. We got to refresh our knowledge regarding the routine drugs which we are using, and glad still bisphosphonate is the first line therapy. I personally prescribe bisphosphonates.
We can
And
have Dr. Vineet expert comments and
just one comment from my side
yes,
regarding
Ashish,
the
yes.
regarding the use of bisphosphonates. Definitely, it is traditionally considered as the first line of therapy in case of osteoporosis. But then I have some restrictions or reservations here, because when you start bisphosphonates, see, there are multiple therapies because there are multiple ways to address the issue of osteoporosis. So you have got the anti-resorptives and you've got the anabolics, right? And if you start anti-resorptives, the problem is when you see that your anti-resorptives are not helpful, then you would want to go to anabolics, right? So, but the problem is when you start anti-resorptives, there has to be a drug-free period of around 6 months. So you start bisphosphonates and you don't get the results, you are stuck there for the next 6 months. So I think if you've got a patient who's more than 70, septuagenarians and very old patients, especially females, who you know that these patients are they have a lot of T score. I mean, they are way down on the T scores. So those patients, I would prefer to start the patients on teriparatide rather than bisphosphonates or denosumab. Reason being that teriparatide would be first of all, it will be more beneficial for them. Secondly, if you see that the teriparatide is not working, then you may switch to denosumab or bisphosphonates, not the other way around. You don't have a drug-free period if you're giving teriparatide. You can directly convert from teriparatide if you don't see the action coming to denosumab or to bisphosphonates, but then not the other way around. Second thing is, if the main limiting factor for teriparatide, I believe, is mainly the cost factor. If you see, the cost factor turns out to be approximately 1.5 lakhs per year if you go by proper drugs that you're using. So that is the main reason why I think it has been kept as the third line of management till now. But other than that, if you see, and secondly, the problems with teriparatide causing hypercalcemia or hyperuricemia, those things can be tackled with monthly, monthly or say bi-monthly. The tests once in 2 months. So those things can be looked at. So I think we need to rethink about the algorithm that we use while prescribing. And definitely what you have said, Dr. Aanchal, was very, very true, that we many number of times tend to start just because we have low T scores. We tend to start, bisphosphonates or anti-resorptives or anabolics. But then the first thing that we need to see that our calcium levels and our vitamin D levels should come to normal before we think about instituting anti-resorptives and anabolics. Second thing, many number of times we just look at the T scores. We fail to see the Z scores because we have been traditionally taught that T score is the one which makes a diagnosis of osteoporosis. What we fail to think is Z score gives you an indication about secondary osteoporosis. So so the difference between T score and Z score would be T score gives you a diagnosis of osteoporosis. Z score compares you to the normal population of your age.
Z score.
Yeah. So Z score. So that's called Z score actually. That's how the
Okay.
Westerns pronounce it. So
Okay,
when you compare that and Z scores comes to less than 2, less than -2, that means you might be harboring some reason why you are developing a secondary osteoporosis. So those are the things that we need to look into. Third thing, what I would want to point out is sometimes we may feel that there are anti-resorptives and there are anabolics. So why don't we combine them together? So if we do that, actually the literature has shown that there is more disadvantages to it. Right? You might see the bone becoming even more weaker and increased chances of bone fragility in such cases. So you can never combine anabolics and anti-resorptives together, despite the logic saying contrary. So these are few things I want to point out.
Thank you, Ashish sir, for your contribution. Ma'am, should we take questions first or should we ask Vineet sir to
Deep, I would just like to add on to this. When we are looking at a patient who is osteoporotic, and first we need to look at what are the aims and what are the functionality of the patient, how much the patient is otherwise bedridden, mobile, because we have to look into the rehab of the patient also. And accordingly, we need to apply or we need to provide or advise the patient to use prosthesis also, because it will take time for the bone growth and bone strengthening to happen. And in case we do not address these things, before the bone strengthening happens, the fractures may come earlier. Plus, the approach shall be multi-prong. We need to look at the calcium. We need to look at the micro elements like manganese, zinc, magnesium, because many a times I have seen prescriptions of many of our colleagues, they do not concentrate on what is the level of magnesium or manganese and along with that zinc to prescribe the medicine. Only a vitamin D3 and plain calcium supplement is given. So that also needs to be addressed. Plus, along with this, the bisphosphonates call has to be taken alongside. So it has to be a multi-pronged therapy, and patient needs to be accordingly advised regarding the exercise that he or she may do according to their age group. We cannot tell everybody to join the gym, but at the same time, we need to address them to how to approach along with the tailor's brace or something with the knee brace, some support prosthetics also we need to support them.
Right, sir. जैसे मैम ने बताया था, muscle mass is equally important.
We can have comments or we can take questions from
Ma'am, should I read out the questions for Dr. Vineet sir and Dr. Ashish sir?
Yes.
Ma'am, first of all, I would like to raise a question to start the debate further. What is the right way of starting alendronates? Whether it is the first thing to go with the monthly dosage or weekly dosage? Which one is preferable and why? Everybody may have their own different experiences. Let's share it, because I prefer to go with weekly dose. And let us see how everybody has their own experience regarding this. Weekly or monthly dose of bisphosphonates.
Dr. Vineet, can you unmute yourself? Dr. Vineet, you there? Can you hear us?
Audible, sir? Audible? Hello?
Hello. Yes,
हाँ
yes,
मैम
you are
अभी
audible.
वो आशु सर का कॉल आ रहा था, उन्होंने तब उठाया नहीं था, उनका कोई वो थी कहीं टॉक थी कहीं पे कम्युनिटी।
Okay.
Okay. So,
Should I take
that
questions, ma'am?
Dr. Vineet is saying, Deep.
so most of the time, what we do is nowadays when the zoledronic acid is available, we usually give the yearly dose of the zoledronic acid, which is much more convenient. Has shown a more robust data as far as the spinal fractures are concerned compared to the alendronate. What we do sometimes, if we have a doubt whether
Sir,
the patient will
your
tolerate
sound
that,
is not, sir, your sound is not clear. Lot of muffling is there. It's not clear. Not able to understand what you are saying, sir. I'm sorry, but not able to understand.
you know, hello?
Yeah, maybe the surrounding noise is too much. Are you out?
I'm outside the clinic actually.
Okay. Maybe what I just for the everyone's what I understood, Dr. Vineet said that they usually prefer bisphosphonates as the first line of treatment, and what they do is they prefer IV for the reason for ease of administration, because it's a once a year therapy. So that's what they prefer. Is that correct, Dr. Vineet?
Correct. And second thing is that even the spinal fracture data is much better with the zoledronic acid compared to the alendronate.
Spinal fracture
Second,
is improved.
yeah,
with
and the second thing is that alendronate is a weekly therapy, so patient may not be left compliant. Second, most important thing which we forget when we put them on the osteoporosis therapy, a lot of the time patients don't take the calcium. And that's become really, really important. So this is the practical challenge. Patient thinks that calcium has to be taken 2 months, 3 months, and then it's stop it. That is something which is we don't want. So we have to benefit come in follow up. We have to emphasize that they have to take the calcium adequate doses of vitamin D. If they don't take that, then even if we give the bisphosphonate, we will not get the complete benefit out of it. So there was a comment that PGH should be teriparatide should be preferred over the anti-resorptive therapy. Usually, as far as our guidelines are concerned, and what we follow in our day-to-day practices, we don't use the PTH as a first-line therapy until unless there is a severe osteoporosis, which includes the fracture also. So if there is a clear-cut evidence of fracture, yes, teriparatide becomes the first-line drug. Otherwise, usually we either start with the denosumab or we start with the zoledronic acid, and both are something which is easily tolerated. Yeah, but whenever we talk about the osteoporosis treatment, actually more than the drugs, it is the other therapy which works much better, like prevention of the fall, which is the most important. And most of the time, we tend to forget to tell this to the patient, like putting a railing in their bathroom, which is very, very important. If they fall, even so, we have seen so a lot of fall happens when there is an osteopenia. Patient has not even gone into the osteoporosis and they come to us with the fracture. So you do the DEXA scan, you find the patient has osteopenia, but still he has the fracture. The prevention of fall, especially in the elderly post 70, becomes very, very important. And second, prevention of osteoporosis is start in the post-menopausal women from the day one. So the emphasizing on the calcium and adequate levels of vitamin D is very, very important in all post-menopausal women. These are the two things. Lastly, teriparatide is yes, anabolic, and the latest one, the romosozumab, is something which is very, very good drug. The only problem with the romosozumab is the cost of it. So it acts as the both anabolic as well as the anti-osteoclastic drug. But we use it, we keep it reserved for the something like a severe osteoporosis with a history of frequent fractures. These are the patients where we use the romosozumab commonly. But otherwise, the line of treatment events give the zoledronic acid and followed by switch to the PTS. Obviously, you have to give them the drug holiday of 6 months and then shift to the PTS. If the therapy doesn't work, but most of the time we have said it works very beautifully.
Okay. So there are certain questions. Deep, can you read the questions to Dr. Vineet and he can answer that? You are mute. Deep, you need to unmute.
Sorry, ma'am. So Sneha Panchal has asked, are SCRM available? What is the brand name and dose?
I think Dr. Ashish
So,
is.
Doctor, we are not using SCRF
Okay, sir. And
nowadays for the
next question.
osteoporosis treatment per se.
Next question
And
is
Max have
any.
got the advantage for the 5 years post menopause.
Okay, sir. Any next question is any clinical algorithm for treatment?
What I told. First, prove that the patient has osteoporosis. We can do the FLAX scoring. We can do the DEXA scans. Both supplement to each other. We don't have the India specific FLAX scoring, but there are the certain Asian data based on that we extrapolate it. So FLAX score plus PMD is something which is good enough to give us an indication whether to start them on the treatment or not. Or any atypical fracture which we can't explain by a normal trauma is something where we should suspect osteoporosis. And these are someone who has got a fracture, treats them with the teriparatide. Someone who has just a simple osteoporosis, start on the anti-osteoclastic treatment, something like either you can start with the denosumab or with the zoledronic acid or the alendronate. And then later on, after 5 years of this therapy, you can reassess and then see what is happening. So DEXA, if we are doing so, we obviously follow with the DEXA. If we are putting them on the anti-osteoclastic treatment like denosumab or alendronic or zoledronic acid, then usually we do the sex so after 1 year. And in the when the patient are on teriparatide, then also DEXA has to be done after 1 year. The only problem with the teriparatide is teriparatide you can give only for the 18 months.
Yes.
Zoledronic acid we give for the 5 years. Denosumab has something which has shown the data to the 10 years it can be given.
Even
That gives us a more.
alendronate has got safety for many years, sir.
Dr. Vineet must be explaining things very nicely, but because of the muffling of the sound, things are not very clear and not very well understood.
Ma'am, Anchal ma'am will brief again. No worries,
Yeah,
sir.
but there is another doubt that I have. Why go for IV zoledronic acid? Because we need to admit the patient looking at the side effects like allergy reaction and hypotension. Why not to go for a
Sir,
monthly dose of
it is
alendronate?
personal. It is
But
personal, sir.
what Dr. Vineet said
It's
was
more.
that he prefers IV because just for the ease of administration, and he has seen a lot of compliance issues with alendronate, and people don't take it that there are other GI digestive systems, and Indian patients are very sensitive for taking weekly dose, and then they forget, and then because of the side effects they don't want to continue it. So yearly dose is just ease of administration, and as I said that it's a nitrogen chain containing bisphosphonates. So they stay in bone for very longer period of time, even though they are in the blood for brief period of time.
And
And
ma'am, how much gap shall be there between the therapy of bisphosphonates and the DEXA scan to be done for reviewing whether it is making any difference on the bone density score or not?
At least after 1 year, sir.
after 1 year.
DEXA scan has to be done once in a year. DEXA scan should be done once in a year after you've started the therapy for the osteoporosis to review how your things are going on.
Dr. Vineet, what's the maintenance you use? Like, for example, somebody has minus 2.6 and you started bisphosphonates and calcium, vitamin D. Repeat DEXA scan after 2 years is now normal. So do you do something for maintenance?
When we put them on the bisphosphonate therapy and considering that the patient already had an osteoporosis, we usually complete it for the 5 years. And then only we give them the drug holiday. So like a 5 injection. So when we treat the patient, we tell them we yearly give you the 5 injections. I mean, yearly we give 1 injection for the 5 years. Or even if we're giving them the tablets, so monthly or the weekly therapy, that also we usually continue for the 5 years and then only we stop it usually. And we expect at least 50, so minimum 15% improvement in the MG over a year.
Dr. Vineet, as I understand, you are using zoledronic acid with a yearly annual dose. But in case people do not agree with that and we have to go for weekly bisphosphonates, is it advisable to combine vitamin D3 and bisphosphonates like rhizophos and vitamin D3 together in a weekly fashion dosage, or no? Is it advisable to start like we can give maybe Sunday we can give rhizophos, and then mid of the week we can start with vitamin D3 60,000 weekly dose? Is it advisable, or shall we have some other regimen for this?
Sir, when we start the patients on the osteoporosis therapy, we usually first correct the vitamin D deficiency. That's the most important thing. We start them on the calcium. Suppose if somebody who is very severely vitamin D deficient, remember all these drugs can lead to hypocalcemia as well. So if someone who is already a vitamin D, severely vitamin D deficiency, something like the level which is less than 10, then we will prefer to first correct their vitamin D deficiency, and 2 months down the line, we can put them on the bisphosphonate. And usually the maintenance dose of vitamin D is once a month, what we give, or 2000 IU per day. So both can be considered.
So vitamin D,
May I
you are
take
saying
next question?
60
Thank you, sir.
monthly.
Ma'am, may I take next question?
Yes, yes, please.
Sir, Vineet sir, is there any need of serum phosphate or serum PTH or urine examination before starting any sort of therapy for osteopenia or osteoporosis?
This is basics, which we already we run the calcium phosphate, ALP, PTH, and vitamin D before we put them on the anti-osteoporotic therapy.
Sir, vitamin D, PTH, and
Phosphate, alkaline
Phosphorus,
phosphate.
ALP, alkaline phosphate, and vitamin D and PTH. This is basic things we always do before we put them on the osteoporotic therapy. Somebody who has got a PTH of suppose 150 and severe vitamin D deficiency, there is already established secondary hyperpara. If you put them on the teriparatide, it's not going to benefit them anymore.
Okay. And next question is by Dr. Saipriya ma'am. They have asked, she has asked, how do we decide if we need to switch from one kind of therapy to another, say from PTH to bisphosphonates?
To bisphosphonate, you can anyway convert moment to stop the bisphosphonate. Or suppose if you find that bisphosphonate is not working, something like if there is a less than 15% DMT change over the 1 year. So in that case, we need to shift to the PTH.
Okay. We have to revise the DEXA scan.
I'm sorry?
We have to revise the DEXA scan.
Yes.
So next question is,
is there any role of LDL in osteoporosis? Do we have to examine that, and alkaline phosphatase?
हाँ सर ने बोला है सर अल्कलाइन
ALP
फॉस्फेटेस
करते हैं सर हम.
ये अल्कलाइन फॉस्फेटेस कराना है सर. कोई बोन डिजीज होगा तो बहुत बढ़ के मिलता है सर वो एक बार
Thank you.
ये सर ने बोला. और सर नेक्स्ट क्वेश्चन इज पेशेंट डायग्नोज्ड एज स्पाइन फ्रैक्चर ऑन कंजर्वेटिव मैनेजमेंट प्रोटोकॉल फॉर द सेम फर्स्ट लाइन ट्रीटमेंट. सो फ्रैक्चर में तो आपने सर बताया कि टेरापेराटाइड
टेरापेराटाइड ही देना है.
ठीक. Next is how we will come to know when we have to stop osteoporosis treatment and when we have to repeat DEXA scan. So you have already
DEXA I told already. Stopping
Yes.
is something which is always very, very controversial when we stop. Somebody who has improved significantly, and if you see that DEXA is coming absolutely normal, in that case, probably we can stop the treatment 5 years down the line, or even after 1 and 2 years of teriparatide. If you see that patient is having the DEXA, which is absolutely okay, has moved from the osteoporosis to osteopenia rates, probably that is the time we will maintain them on the calcium and vitamin D, and you can pull out on the osteoporotic therapy. And then do the yearly DEXA and see what is happening.
Okay. So next question is, which should we prefer, bisphosphonates or denosumab?
Okay.
So it's either.
So denosumab is also very good as far as the spinal fracture is concerned. Ease of having it, patient can take on their own 6 monthly therapy, very easily remember, and the side effect profile is almost same as the bisphosphonate. The only problem is the cost of the therapy is definitely on a higher side.
Sir, have you ever observed that at the end of 5 month or fourth month or 5th month, the patient start experiencing pain with denosumab?
See, the denosumab, the problem is if it has to be given, it has to be given in the 6 months. You can't delay it for a very long period because then the fracture risk increases. The
नहीं वो तो
atypical
सर
fracture risk
6 मंथ
actually.
पे तो देना ही है, लेकिन आपने सर अपने प्रैक्टिस में ऑब्जर्व किया कि 5वें महीने में पेन आना शुरू हो गया पेशेंट को, या
अभी
छठे
बहुत
महीने
ज्यादा
की
था
स्टार्टिंग में?
तो I'm not aware much.
ऐसा कुछ होता है सर इसमें इसके साथ?
मैंने पढ़ा भी नहीं है और ऐसा कुछ देखा भी नहीं है.
ठीक है सर.
Yes.
ओरल बिस्फॉस्फोनेट्स फॉर हाउ मेनी मंथ्स?
As we said, we will continue for the 5 years.
Okay. We have seen one patient having very bad effect of zoledronic acid developing into AKI on dialysis despite of previous renal workup normal. Practical question: which drug is safer comparatively?
So, this is something which is the side effects which can happen with the any drug. So, I mean, we don't change our treatment decision based on the one patient's experience on this.
So for last question, sir, for an osteoporotic patient, how should we plan for steroid-based intervention? Should we avoid altogether?
That is something which is a double-edged sword. Somewhere where it is needed, it is needed. Somebody who is with the kind of ILD or on the athletics or on the rheumatoid disorders which requires the consistent steroids, that is something which you can't avoid it. You have to give this, you have to give it. And you have to treat the osteoporosis along the side. But use the steroid judiciously. When you need it, then only give it. Otherwise, please don't use it. And
Aanchal ma'am,
obviously, you have to maintain the calcium levels and vitamin D level.
Aanchal ma'am, this question must be like injecting over the medial branch or
Yeah, I mean, selective nerve root block. So the reason we took this topic was because when the patient comes to us with low back pain, sometimes it's not the facet, sometimes it's just osteoporosis which is bothering the patients. So we do the procedures, but one time, as Dr. Vineet said, one time injecting the steroids is not an option. If it's required, then it's required. But then you have to keep treating the patient as well for osteoporosis.
So next question is, post-menopausal women, what do you prefer, SCRMS or anabolics?
It's a fracture that was developed in actually seen within the 5 years, and I don't know whether it is available or not. 10 years.
SCRMs.
So usually we start them on the bisphosphonate.
Bisphosphonate is
Bisphosphonate, okay. So next question is, can we start teriparatide even if PTH levels are normal?
If the PTH is normal, then only we will start the teriparatide. If the PTH are on a higher side, we don't start on the teriparatide actually. We need to first correct the PTH and find out why PTH is on a higher side.
No PTH if on higher side, only if on lower side or normal.
Normal.
So it won't be low, it will be on a low, normal side actually. Low means you are dealing with the hypoparathyroidism, which is very rare. And you need to find out why the patient has the hypoparathyroidism.
और सर DEXA स्कैन सिंगल साइड, ट्रिपल साइड, 5 साइड क्या ऑर्डर करना चाहिए सर आइडली?
For osteoporosis, always order for the 2-side DEXA, which is good enough. If and is fine.
Spine and femur neck.
Forearm we do only if you are suspecting hyperparathyroidism and the parathyroid adenoma.
Forearm only.
Because the maximum damage you see at the forearm in hyperparathyroid patients.
Okay. आज एक पेशेंट आया था सर, उसका फोराम में बहुत ज्यादा था तो मैंने आपके लिए रेफर करा था उसको. Anyone else wanna add? Ma'am, any closing message?
Yeah, I think as Dr. Vineet said that we need to thoroughly just seeing the T-score is not good enough when patient comes. We need to see if the symptoms are contributed because of osteoporosis. Once you see osteoporosis, you see if it's primary or secondary. Do all the blood tests, especially along with every regular test, parathyroid hormone level. See if what you are treating, whether you are treating secondary osteoporosis, primary, and then based on severity, you start with your first lines, do the maintenance therapy, do the yearly tests, and of course, people who can do exercises and the other nutritional advice you have to give. So it needs to follow with the overall thing.